So pretty broad. Kind of the concept of normal behavior is a little bit interesting to try to, figure out exactly what's normal and abnormal behavior, what qualifies as an emergency. So there's not really like a normal. It's kind of like whatever society accepts, and this kind of depends on the culture, kind of the group you're with. So there's not really a normal. So how do we kind of concept what is abnormal? And I guess the best way to say is like what is adapted to like what we would normally do, or what is like the society acceptance of like what a normal adapted person would do in whatever situation they're in. So I guess when we see that people are kind of deviating from that normal, the spectrum varies, of course, but that's kind of when we start to consider behavior abnormal to start with. Um, and kind of that spectrum leads to, is it harmful to the patient or themselves, which is really the kind of what we're trying to tease out when we respond to these calls and decide whether or not they need to come into the hospital, whether or not that's voluntary, involuntary. So usually these calls are for some kind of episode that's not anticipated. Sometimes it is anticipated, in fact, that they have a history of it, but usually these situations are out of control of whoever is calling, or sometimes the person who is calling is experiencing the emergency and feels like it's out of control with, to themselves. So that's kind of where we come in on this kind of more severe spectrum of kind of abnormal behaviors. Um, so obviously there's a lot of psychiatric disorders, there's a lot of you know behaviors that in a particular instance can be considered a psychiatric emergency and not necessarily associated with the disorder. There's all sorts of underlying causes, medical, substance, hereditary, emotional, kind of comes from all different places. So it's a pretty big topic to try to sort out exactly what's going on. This was a list out of a textbook of kind of general things when you're looking to decide if somebody's behavior normal, abnormal. Is this starting to follow trends of what we might see in some certain psychiatric illnesses? Is this something that might hint to us that they are on something or have taken, a substance that we don't know about? Obviously, if they're confused, delirium is referring to, we'll kind of go over it later, but kind of an acute change in their mental status. So that's a big red flag that something is going on, whether they took something, whether something medical has come up. The acute change is really what we try to tease out within the history. And some of these other things you'll kind of see, we'll go through kind of individual disorders, and you'll see some of them are associated with some of these things. This is kind of just a general list of abnormal behaviors based on kind of categorization. Like I said, a bunch of different types. We'll try to touch on almost all of these. So there's definitely a mental health issue, and it's been exacerbated over the last at least 10 years, and then probably even worse since COVID. As high as 20% in the population is kind of the estimate. Some of these are more common, less common, but just in general as a group of disorders. So that's like 1 in 5 people. And I think now it's becoming more normalized to talk about, if you yourself have something, or you can relate more than it used to be, because it's previously a lot of stigma. But, estimating that 1 in every 7 people will require treatment, that number seems like very high to me, but I guess, at some point in your life, it's not impossible for them to be the they and us to be the us. It's all about relating to the patients. So I guess misconceptions surrounding behavior. So is bizarre behavior illegal or wrong? That's kind of like where we get into trouble, where we try to bring people in, or maybe they're just having bizarre behaviors, but not necessarily a harm to themselves or others. mental disorders are incurable or kind of untreatable. Another common misconception. All the patients are unstable and dangerous. Even those with history of violence in the past are able to be controlled and treated for psychiatric illness. And then kind of what we talked about is like it being stigmatized, like a reason for them to be shameful or embarrassed. So what causes this? We talked about this a little bit. Honestly, it could come from a lot of different things. When you guys bring a patient that has psychiatric complaints to the hospital, the first thing we do is rule out organic causes. So we pretty much have a basic laboratory workup that's pretty comprehensive that we run on pretty much anyone. If we're suspicious that there might be anything in the head, if they're getting a head CT, they get a pretty thorough workup, even if it's somebody we know has a background with psychiatric behavior disorders. Just because we don't want to find that reason why we could have just treated that and then they would have been better. Some of these other things are a little bit harder to identify and fix. The psychosocial causes, usually that takes a lot of listening and talking with the patient and sometimes working with either case management if you're in the hospital or kind of asking around for family and collateral information, kind of for all of these things. And some of these things people are not upfront about talking about, so it's a little bit complicated to kind of divulge, especially in the emergency setting. So I guess general assessment when you get called to this type of like behavioral response call. The first priority is to figure out if you yourself are in danger, if this patient is deemed to be violent, and that's going to call more resources. So you're never going to put yourself in like first line danger for somebody without backup or without somebody else, because this is just going to cause us to, more patients. You're going to become a victim yourself. Some of these situations are very volatile and unexpected. So obviously there's kind of deem that there's no threat, then we go through kind of our normal type of interaction with the patient. If the kind of the spidey senses go off, I think a lot of extra information that you get at the scene is useful to pass on to the hospital, especially. So maybe there's not any active maybe you didn't find the patient with a needle in their arm, but maybe you notice on the side of the table that there's something there that maybe they could have used. There's something in the garbage. If there's just kind of, even when you guys tell us about the conditions of the housing and kind of where they are and what the situation is, it's useful to try to get like some of this collateral evidence of what's going on. So in general, this is kind of a double-edged sword to try to isolate the patient because you don't want to be kind of one-on-one if somebody's potentially dangerous. But at the same time, you want to decrease the stimuli that's happening around the patient. So maybe that's not necessarily isolating the patient with like a certain amount of people, but maybe it's taking away from loud background noise, taking them outside, taking them to somewhere where they can focus a little bit more on the conversation, where you deem you're still safe. So all this is kind of going to be a judgment call about what's going on with the scene. And then in general, you're the first contact to kind of say, is this something that's like a medical emergency, or am I dealing with something I think is really, really psychiatric? And you don't have to have the final answer to that, but if you notice that the patient is like, dripping sweat and diaphoretic, and they're also, super agitated, and there might be something else going on, that kind of flips our gear to maybe think with a more medical hat than just, sedating the patient and not really knowing what interactions we might encounter. So obviously the ABCs, we're observing the behavior, we're monitoring their mental status, and also kind of what I guess kind of emotions they're giving off to you can be a big clue whether this is like a safe encounter, whether this patient really needs support, or kind of is this more of a medical patient. So there's several psychiatric medications. So when you guys look up or ask the patient or look up in their MedRec from whatever facility you're picking them up what medications they're on. They can kind of clue you into probably what type of diagnosis the patient may have. So basically figuring that out, figuring out if they're still taking it. A lot of people who are having like manic episodes or like their schizophrenia is really heightened. A lot of times it ends up being related to medication noncompliance because most of these people, if they've had long-standing mental health issues and followed with a practitioner, typically these symptoms are under control most of the time. So if you see some of these things, I mean, the Haldol, we'll talk about that from the perspective of us giving us as well, but it can be used as an antipsychotic. So that's kind of a clue that there's something going on. Thorazine was like kind of an old school drug. It's common for schizophrenia. SSRIs, SNRIs are everywhere. Common for depression, anxiety. A lot of people are on these day to day. Okay, so kind of trying to hone in when you're actually talking to the patient. Establishing rapport, I think, is like the number one thing there. So a lot of that is just listening to what they have to say. Even like the most intoxicated patient is like, listen, I'm trying to say this. I found for de-escalating and kind of figuring out what the goal of the encounter is with the patient, a lot of times if you like listen to what they say and summarize what they're trying to say back, then at least they know that you've heard them and have said it. And usually that's enough to establish some kind of rapport, like we're trying to work together to achieve whatever goal that was. And kind of shows that you're supportive and empathetic at the same time. Threatening actions, threatening statements. I see a lot of this one with substance abuse, especially if we're kind of either reviving them with Narcan or we catch them taking someone or taking something and we think that there's drugs on board. A lot of people are like, what did you take? What did you take? Screaming at the patient in their face. So probably not the best approach. Kind of stepping back and maybe the patient will open up a little bit more or even just some time with the patients themselves. Obviously, we want to kind of limit physical touch, especially initially until we establish this rapport. It can kind of help with safety on both ends. As far as kind of assessing where they are intellectually, so this kind of comes down to does the patient have capacity is also kind of a big question that might be tied into some of this, and we don't directly address it on this slide. But kind of their function, so orientation, you guys all know, place, time, self, that type of thing. Memory, short-term and long-term can sometimes be the differentiation between a lot of people who have like dementia versus a delirium. A lot of times in dementia, long-term memory is preserved, whereas in where short-term memory kind of suffers. And then usually in delirium, it's like there's really no kind of rhyme or reason to what's going on. Concentration. This, I mean, some people have poor concentration at baseline, but can help kind of clue into maybe substance abuses can cause short concentration. If they have a lot of internal stimuli that they're trying to respond to as well, the concentration, a lot of times they can't even focus on what you're saying. And judgment. So, are they kind of making the choices or responding appropriately for kind of what the situation is calling for? And then with their thought content, we usually describe like a linear thought content, like you can follow their logic to what they're trying to say. If they're kind of like all over the place and are saying things that don't make sense, that's more of like a disordered thinking. Delusions and hallucinations, sometimes this is really hard to sort out, like are they having delusional thinking or is some of this actually real with some of the stories that people are saying and confabulation that can happen. So a lot of times, like in the immediate setting, we might not know if the delusions are delusions or if they're real. So until you can get kind of collateral information, I typically will trust what the patient is saying to me unless I have reason to believe otherwise. And then I think that unusual worries and fears kind of grouped into that. Okay, so we're looking at language. I think we look for either very like slow speech where it's kind of like taking a long time for them to process, can be that kind of hint that things are abnormal. or a very rapid pressured speech can be on that other end where the patient might be a little bit manic. And then garble, I didn't do that on purpose, or unintelligible speech. You know, we're always kind of watching that because we're concerned for maybe like stroke, especially with some of these situations where altered mental status is at play and there's kind of non-specific symptoms. Mood of the patient, we kind of talked about how alert they are, and then general appearance and hygiene. The eye test kind of does a lot. Just kind of seeing the situation that they're in too. You guys had like a little bit more in-depth view of that. And then their psychomotor activity refers mostly to like twitching, or are they doing certain movements that seem a little bit odd, tics, that type of thing. This was an acronym that was in here to try to remember, I guess, the majority of these categories and maybe some quick questions to ask to assess for these things. So, level of consciousness, you guys, we do this all the time. Are they awake, alert? Are they drowsy? Are they somnolent? Are they like completely unresponsive? The concentration we talked about. Orientation, not only I guess to place and time, but also kind of to situation is I think important, and grasping what's going on can tell you a lot about both of their insight and judgment as well as their orientation. And then some of these other ones we went through. Your secondary assessment. So this is where we kind of like rule in, rule out some medical things. So skin temperature, moisture, are they super dry? Are they febrile? Is this leading to why they're altered? And pupillary exams important both for substance abuse and also for any intracranial, is there a density that's responsible for all of this? Odors on the breath, substance abuse, even like a DKA patient that might be to the point where they're so lethargic and altered. And then examining the extremities. So if we can, find evidence of drug use, it's always helpful. Tremors, and then of course we're always kind of doing that stroke assessment in these altered patients as well. Okay. So reassessment. So this is kind of like you're already on your way type of thing. You can provide information, especially if past medical history is helpful, what medications they're on, if they have access to other medications, or if there was evidence of drugs, that type of thing as well. And then kind of what you noticed from their mental status exam and kind of all the things we talked about. And please, please, please give a heads up if the patient is aggressive or violent, because once you guys have that situation controlled, we'll also transferring the situation can also exacerbate that, and we have to make sure that we have enough people on our end too. And I guess psych illnesses are typically a diagnosis of exclusion, like I was saying. So there's plenty of other things. Severe anemia, like a CO2 narcosis or even hypoxia can cause patients to be altered and combative. If they're postictal, we get combative patients all the time like that. So the chest pain that is probably an anxiety attack, but it still needs to be investigated for what it is. So this is just in general, this is like the general approach. So spend the time with the patient, try to establish that rapport, try to understand things from where they're coming from, no matter how intoxicated or maybe delusional they are coming across. If you can acknowledge kind of what their goal is, it's going to help both of you get through the encounter safely. And then we'll talk a lot about kind of restraints, chemical restraints, and how we can utilize law enforcement and things if patients are dangerous. That's part of the next section. This is the overview on cognitive disorders. So this is kind of encompassing delirium and dementia. So like I was saying, delirium is usually like quick onset. It happened over the last few days. This is usually where we start thinking there might be some reversible cause, whether it's medical or otherwise. Substance abuse is a big one. Acute medical conditions can cause this. It's kind of like all over the place, very big category. But like I was saying, the memory impairment with this is a little bit different than your typical dementia patient. And obviously, collateral in the timeline is helpful to tease that out as well. And knowing what the patient's baseline mental status is extremely helpful. If you can obtain that from whoever was at the scene or was at a nursing home, I know it's difficult all the time to call and they're like, so as much as we can, try to make the effort to at least know what their baseline is and know how far away from that we are. Dementia, so a couple different kinds of dementia based on kind of what is causing it. But this usually long-term memory is fairly intact, but it's more of a short-term memory issue, and that's kind of like questionable for when their dementia was onset. If they've had dementia for 20 years, then they might be missing that kind of 20-year chunk where they really had a good memory. But a lot of people remember things from childhood and things that go way back. You guys probably know what aphasia is. Do you guys know what apraxia and agnosia is? I guess that's inability to move, and agnosia is inability to like recognize objects and name them. So some fancy medical terms there. But usually these people are, they'll kind of give you a story and you might believe it because they're basing it on maybe some of their older memories. But as you kind of dig more into things, you'll kind of see that their ability to organize and kind of like follow through a linear thought process is missing. Schizophrenia. So there's a couple different types of schizophrenia. There's the paranoid kind of category to it. Some of these people have all of these things. Some people have very specific parts of these things. Usually comes with being disorganized. Catatonic states is kind of like where they are almost like non-responsive to what's going on externally and more involved with internal stimuli. So this is in general are people that are either having auditory, less likely visual hallucinations. They're withdrawn. They're usually disorganized, disheveled. They don't care for themselves. They're very distracted by what's going on internally. So these are kind of some of the things. I did like a psych major when I was in college, and they had us do an exercise where we rolled up a piece of paper and we were whispering in somebody's ear while they were sitting across from somebody trying to interview them. And the person in the ear was like reading a story, and they were like, okay, try to respond to the person interviewing you. And it was like a concept of like how it is to have kind of that internal stimuli and like why they're so distracted and why can't they answer my questions. So if you kind of like put yourself in that situation, you can kind of see why it leads to some of these things. A lot of auditory hallucinations when it escalates to the emergency room is because I had voices telling me to harm myself or kill myself or kill somebody else. And that's like the really dangerous behavior that we're worried about. Those people usually always get inpatient stays. But it's trying to maybe catch them to the point before it escalates to actually being actionable. So they can be really heightened in that perspective, or sometimes they appear totally flat in like the catatonia that I was describing, where they're just like they're not responding at all. So these are patients that can get violent. Usually they are a little bit volatile as well. So we'll talk about kind of what medications are best for which situations and sedating patients, but obviously restraining is either chemical or physical if it's going to keep everybody safe. This was a couple of stuff Bernadette threw in about a case study between identical twins and some MRI findings that were different between the head schizophrenia and not. So there was a couple findings on MRI that had to do with like the size of the ventricles, Um, some things on PET scan that showed like reduced activity on like a functional PET scan. So just kind of interesting that there's actually like physical changes that are going on in these patients, not just kind of all in their head. This story is kind of referring to like a young person that was like really highly functional. It sounds like when they were younger. Usually when we see the onset of schizophrenia, it's like late teens, and then kind of the age group we stop diagnosing it in is the early 30s. So like really kids in that like college age is usually the first time they have a break. So oftentimes like roommates are recognizing, you know, their college roommate isn't like sleeping and they're really messy all of a sudden and they're not taking any care of themselves. And sometimes it can be like a couple months where it really becomes apparent to everybody else. But that's the age group that we kind of look for like this initial presentation. Anxiety disorders. So I read this slide. It said affect 2 to 4% of the population. I was like, there's no way that's true. Like, it seems like it's way worse. And I did see that since 1990, it has increased 18% and is now close to 20% of the population. So that was like more similar to numbers that were seen in the 90s, whether it's more recognized, less stigmatized, or people are kind of going to healthcare providers for treatment. I think all contribute to that number being increased.
I think with all the mental health push in the last few years of it's okay to be kind of off, that more and more people are actually reporting. So I think we have a much more accurate
number of like who actually has it, yeah, rather than just like so this is more focused on kind of when the anxiety disorder is out of control, where it results in a panic disorder or like severe phobias or PTSD. So kind of these are more focused on panic attacks and like exacerbations of the anxiety. So usually we get these as like a chest pain, shortness of breath type of complaint or call. I guess part of it is obtaining the history of like prior episodes of this, but also kind of our clue in is usually symptoms are pretty quick onset, and then they're there for up to maybe 10 minutes before where they really peak, and then usually there's kind of like a decline after that. Obviously, we have to rule out other things as well, but it can help if you kind of recognize this to help calm the patient down and de-escalate them from this perspective, rather than maybe hyping them up like, oh, I think you have a heart attack, that type of thing, because that's like kind of a vicious cycle. Because a lot of these things are things that we do see in our sick cardiac patients or patients in respiratory distress. So, like I said, usually it's like a 10-minute type peak thing, and then the patient can usually be de-escalated at least a little bit. Sometimes it's like they go up, or you bring them back down, they go back up again. So kind of teasing out what is making the patient feel more calm. If they're getting calm and their symptoms are starting to resolve, that's kind of like this is probably what's going on. At least this is how I, can kind of mitigate this as we're on our way to go get a bigger workup. And a lot of people will like describe like a feeling of doom or like losing control. Some people can't identify what triggered it. Sometimes it's pretty clear what triggered it. They saw something traumatic and now they're having a panic attack. So, or they got in a fight with somebody and now they have chest pain, that type of thing. So, like I said, usually we do like a full workup on these patients, even if we have high suspicion for panic attacks. I would still run a 12 lead on all your patients that are presenting as maybe a suspected panic attack. Treating the hyperventilation, usually that's just de-escalating them. And if you feel like it's really unsafe, like following medical direction, to maybe use some of the medications that we have, and we'll go over to try to calm them down. If it's really going to be worthwhile to help them get to the hospital. Phobias, usually these are like kind of like triggers for acute panic attacks. So usually there's some kind of exposure, whether it's insects, bugs, flying a plane, like that type of thing. Usually people are aware that that is the trigger, or at least can tell you what made them so upset in the first place. PTSD, there's like way like more and more research on this all the time, so it's definitely a really interesting topic. There's a lot going on trying to figure out what actually changes in the brain after a traumatic incident that leads to PTSD. I think we see panic attacks also precipitated by PTSD or being triggered about, recurrent memories or things like that. Some of the stuff presents as just like general depression type symptoms. There's usually an element of survivor guilt or like witness guilt. Frequently, people will try to treat this themselves with substances, alcohol, that type of thing. So usually it kind of pairs hand in hand with some kind of substance abuse. Population's most at risk, so veterans, like they're seeing greater than, I think, 10% formally diagnosed, and like there's a threshold of people who have symptoms that are not diagnosed. That's a very large number. There's more and more research on healthcare workers in general, and even EMS providers. So numbers, I think, are a little bit all over the place, but I think at baseline, they've found over 50% of healthcare workers in some form have probably sub-threshold, like symptoms of PTSD that are formally diagnosed or recognized as PTSD just from all the kind of secondary trauma that we encounter. So I guess in this case, when you guys are addressing this, trying to be supportive, compassionate, that type of thing for patients and trying to de-escalate them, especially because this will probably be something that they say that this is triggering for me. I'm feeling upset. So, any questions on that? I think now there was a built-in break. Is this a good time, or you want to power through a little bit further? I've been going for like 45 minutes.
Are you awake?
Do you want a break?
I'm good. I'm like on a roll. I worked 8-hour shift here.